Rupesh, Prabhu,
Yes, sir.
just because I don't know, I think who all are going to go offline after their talk. I think Rupesh is going to go. I don't know about others.
All others will be staying, sir.
All others, only Rupesh, right?
Only
No?
Rupesh is off.
So, should any questions for him should we take after his talk, or we'll keep, because at the end he will not be available. If it is okay, we can keep it then, or if you want to just after his talk to spend 2-3 minutes to ask if any questions, you think about it.
Questions will be in the chat box. They will
Yeah,
write it in the
yeah,
chat
yeah,
box.
yeah.
I'll just see if any questions are raised at the time
Because
of his presentation.
because later if anybody is asking for specifically for a speaker who is not available, it will may not look nice that he is not there to say that. That's why.
Yeah, that's why I
But
asked
Kathleen,
Kathleen,
Dr.
madam.
Kathleen told me she will
No,
answer all
madam.
the
She will
Dr.
answer.
Kathleen will cover every topic. That is different.
No. I can ask the questions.
No, that's what I felt like. No, in case if there is something for him, he might as well complete it then and then.
Yeah, that's we'll just see after Rupesh talk. Any questions are there, we'll ask him directly. Otherwise, we'll go for the next talk.
Yes.
Because we have another this NSI program at 6:15 or 6:30.
Okay. So the same Zoom link goes there, is it?
I'm not sure, but it is an online exam for the PG students
Oh, that
conducted
may
by
be
NSI.
different. That may be different Zoom link.
So they have asked us to stop at 6:15, 6:30.
Oh, okay. I think no, we can wind up. We can keep that as a hard stop and then do that.
Yeah.
How often you do these webinars? Once a month?
Twice a
Oh,
month.
Dr.
twice a
Kathleen, that's a very difficult question to answer because there are a lot of webinars which are happening across various societies. In NSI, they do it probably monthly, and every time they try to combine. There are webinars like what just Dr. Prabhu was mentioning. After 6:30, there is another program that is an online exam for the students. So because a lot of students and the institution trainings are kind of varied, so NSI has taken the onus of conducting online exams where a student is made to present like an exam, and then so there are different program webinars is where we have these kind of experts talking, and these webinars are going, as you know, like in other international societies. Here also NSI conducts webinar. These other specialty societies also conducts webinar. So I think national webinars, we will have at least one or two in a week from some society or other. NSI webinars, I think like maybe once a month.
No, twice a month.
Yeah.
Dr.
Twice a month.
Kodishwaran is there.
Yeah.
Dr. Kodishwaran is the NSI
Yeah, he is a
webinar coordinator. Sir, you can talk 2 seconds on this, how webinar goes.
I welcome everyone. So this is Dr. Kodishwaran, Chair NSI Webinar Committee. Myself and Matthew Abraham is another chair of Webinar Committee. We hold 2 meetings per month on every second Saturdays and fourth Saturdays. So for second Saturday is the Dr. Matthew is conducting, and fourth Sunday 24 webinars. So this year our 75th celebration. So we are connecting all societies once every month.
Dr. Madhu, you can start the proceedings.
Shall I start,
Yes.
Dr.
Madhusudan?
Yes, sir. Sharing my screen. Yes, it's 4 o'clock. So good evening, everyone who have joined us from all over the country and over the world. Today, we have a joint initiative by Neurological Society of India and Society of Intraoperative Neurophysiological Monitoring to host this webinar titled IONM Mastery, Shaping the Future of Safer Neurosurgery. We have an excellent lineup of talks lined up for you today, covering spanning across the multimodal intraoperative neuromonitoring for eloquent cortex gliomas and spinal surgeries, including dystrophism and deformity corrections. It is my honor to serve as coordinator for this webinar, and I request all the attendees to make this an interactive session. Post your questions on the chat box, and we'll be taking up all the questions at the end of the session and answering all of your queries. I now introduce the moderators for the session. So, Dr. Prabhurat sir, he's a professor and unit head in the Department of Neurosurgery in IMANS, Bangalore. He has expertise in neuro-oncology with special focus on tumors in eloquent cortex and spinal tumors. He has done extensive work on intraoperative neuromonitoring, brain tumor mapping, and awake craniotomies. And he has received various national and international awards for best paper for his work on intraoperative neuromonitoring. He also served as the organizing secretary for the last ScionCon 2025. I welcome you, sir.
Thank you.
Next, we have Dr. Kodishwaran M. He is the professor and head of neurosurgery at Kilpauk Medical College, Chennai. With over 2 decades of experience in the field, he has his special interest in neuro-oncology, functional neurosurgery, and spine surgery. He is a current EC member of Neurological Society of India and the current webinar convener. I welcome you, sir. And also we have Dr. Matthew Abraham. He's the current head of the Department of Neurosurgery at Lisi Hospital, Cochin, with special interest in epilepsy, vascular and skull-based surgery. He's also the current EC member of Neurological Society of India and the current convener of webinar committee. I welcome you, sir. I now invite Dr. Prabhuraj to introduce the panelists and the speakers.
I welcome you all for this webinar. I request Dr. Kodishwaran to talk a few words on NSI and ScionCon so that I will take the proceedings from there.
Yes. Thank you, Dr. Prabharaj. So on behalf of Neurological Society of India, I welcome you all for this wonderful academic event. So this year, the 75th year of Neurological Society of India, and also we are happy to host Society of Intraoperative Neuromonitoring in our academic session. So today we have invited Dr. Prabharaj to host this session. Since I apologize because we are traveling from Jaipur to Chennai, so I may not be able to be in the session. Dr. Matthew will be there. So Dr. Matthew Abraham is another convener of webinar committee of NSI. So Dr. Prabharaj will take over the proceedings, and I welcome Dr. Prabharaj.
Thank you, sir. So we'll straight away go for the introduction of the panelist. There are 2 panelists for the section. The first panelist is Professor Arivalagan. So he is a professor and head in the Department of Neurosurgery in IMANS, Bangalore. He has a special interest in epilepsy surgeries, neuro-oncology, endoscopic and skull-based surgeries. And currently he is the Society of Intraoperative Neurophysiology Monitoring Secretary. And I also welcome Dr. Anand Balasubramaniam. He is another second panelist. He is a principal consultant, professor and head of the Department of Amrita Hospitals, Faridabad. He has a special interest in functional neurosurgery, movement disorders, epilepsy, stereotactic endoscopic neurosurgery. He has a lot of experience in neuro-oncology, radiosurgery. He is our alumni and he is our associate professor in NIMANS. He has done a lot of fellowships in Toronto, Pittsburgh, and Munich. And presently, he is the president-elect of the Society of Intraoperative Neurophysiological Monitoring. I welcome Dr. Anand and Dr. Arivalagan as a panelist for this beautiful webinar. So I take a privilege in introduction of the speakers. We have a line of speakers in which the first speaker is an international speaker, Dr. Kathleen Siddle. She is the attending a staff physician, Department of Neurosurgery in Spital, University Hospitals of Bern and Switzerland. And she is the head of the Department of IONM in Bern, head of the Department of Navigated TMS, head for the machine learning and artificial intelligence in intraoperative neuromonitoring. And currently, she is the president of International Society of Intraoperative Neurophysiological Monitoring. She does excellent work throughout the world, and she sensitizes this IONM work throughout the world. She has been under so many professors. She has been trained, and now she is training a lot of students as well as a lot of faculties into this intraoperative neuromonitoring. I welcome her for this webinar. The next online is Dr. Rupesh Kumar. He is the Director of Neurosurgery in MGM Healthcare, Chennai. He has special interest on skull base surgeries and cerebrovascular surgeries. He is well known for his tumors, minimally invasives, and spinal surgeries. He has a lot of president-elect in TANS, president's past secretary in skull base, in SeonCon, the past chairman of the Young Neurological Society of India Society, ex member of Cerebrovascular Society, ISNO, and Neuroendoscopic Societies. So I welcome you on the board. The second speaker is Dr. Shushant Sahu, a young dynamic person who has done recently his fellowship with Dr. Dufa. He is additional professor and Department of Neurosurgery, PGI Chandigarh, and his special interest is on awake craniotomies, brain mapping for eloquent region brain tumors, neuroendoscopy and skull-based surgeries, and gamma knife radiosurgery. I welcome you, Dr. Shushant, to this webinar. I welcome Dr. Edmund, is another young dynamic person, professor of neurosurgery in Department of Christian Medical College, Vellore, a special interest in skull base, cerebrovascular, and a lot of spine surgeries. Recently, his interest is on UBE, and he has done a lot of fellowship in South Korea, and he'll be talking on the deformity monitoring. The last speaker is Dr. Vishaka Karpe, and she is a senior consultant pediatric neurosurgeon. She is from Rainbow Children Hospital, Hyderabad. Special interest on IONM in pediatric neurosurgery, spinal dystrophism surgeries, craniostenosis, and hydrocephalus. So with this lineup of the young and dynamic team of this IONM webinar, one thing we want to tell is this is the last slide. This has been requested by Dr. Ali Esker and also by the Society of Sion to put this slide, because this is the International Society of Intraoperative Neurophysiology Monitoring to be held in Mumbai from November 2nd to November 8th. A very big conference, an international conference to be held in Mumbai. Talk about intraop neuromonitoring webinar. Within 2 hours, we cannot cover many of the topics in IONM. So it's just a gist of little bit on supratentorial and little bit of spine. Anyhow, the brainstem and the cranial nerves and other things we will cover. Maybe if they give a chance for the second part, we can cover that also. I thank the NSI Society so that we have hosted this webinar. I hope that the persons who have joined, I think it's already about 125 members have joined. It's a big group we are going to talk about. So without wasting time, I'll request Dr. Rupesh Kumar to talk in his talk.
So thank you, Dr. Pravaraj, for this wonderful opportunity to speak, and nice to see Dr. Kathleen after a long time. And I think this is a very good initiative from the society, from both the societies. And IONM being very much coming up, especially with a lot of interest among the neurosurgeons, younger neurosurgeons. I think this point of discussion is very valid. So now I'll be covering more on the cortical and subcortical mapping of tumors in and around the motor cortex. What are the strategies for maximizing resection and preserving function? So as we know, motor cortex is a band of homunculus, motor homunculus, earlier described. And I have put a picture showing fingers and face as a large. And that is how it is represented in the motor cortex. You have a much larger representation of hands and face than the rest of the body. So what does it implies is that is if we can monitor the hand function and face function, we are by and large monitoring a large areas of the motor cortex. Now, if you see the mapping of the motor regions, the mapping doesn't start in the OR. It actually starts preoperatively, the radiology. So if you have a scan like this, in a young man who has a progressing right hemiparesis, you see a large tumor heterogeneous in the motor cortex. Now you should know where is your hand area. Is the hand area displayed anteriorly or posteriorly? Say vice versa, the face area, the leg area. So it's important that we have the mapping of these functional areas even before surgery using our MRI. So that will give us a three-dimensional orientation. So during an OR, that how we can plan and strategize our surgery. For example, if you see here that hand area is more lateral, and then the leg area as per medial, and then the face areas are much more lateral. So here we are concerned about the hand area, more closer are the leg areas. So we get this idea so that, and then we can extrapolate it during our surgical procedure. So for every given case in tumors in and around, you need to know your functional areas, how they are displayed in and around the tumor. Now, equally important is the subcortical mapping, subcortical fibers, how they are displayed in and around the tumor. So that will help us to select the entry point and where we should start monitoring the subcortical fibers, because rather than from the beginning, we can know here that once you have removed this tumor, how starting your subcortical mapping and monitoring. So this type of subcortical mapping even really gives us a much better idea before even we go into the OR. Now, the other silent areas of the motor cortex, something like the fronto-oscillary tract, as you see here, so you know that the tumor is SMA syndrome. So you know the frontal oscillary tract is going to be very important. And you can see, so these also can need to be monitored. So you need to know where these frontal oscillary tracts are. As you see here, they are going to be just posterior. And here also, if you see here, the frontal oscillary tracts are just behind and inferior. So these are the other areas also which should be giving equal importance to plan our surgery. Now, these type of mapping cannot be done in unconscious patients or pediatric patients. So we know the role of connectomes, which are coming up in a big way due to the functional areas. Even the so-called non-functional areas also can be mapped using these connectomes. So having now come to the radiological information on how and where the motor tracks are, then we go into the OR and start doing our mapping. So one of the foremost and important thing is about the central sulcus. So any region in and around the Rolandic area, we should know where is the central sulcus. So that will give us a very valid information. So basically, we think that the central sulcus mapping is by MEPs, but the converse is true. Actually, it is the SSCP. So the SSCP monitoring is actually helpful to map the central sulcus because we have the positive and negative dipole wherever the inversion happening, and that is going to be the central sulcus. And anterior to that is the motor cortex and posterior is the sensory cortex. So any tumors in and around, this is a very important initial step to know where is your example. So example, as you see, you expose this area and you have a tumor here, and then you keep your electrodes to know where is your electrode. We can see in this case, we can see that in between second and third electrode, there is an inversion. So we know that, so that is a motor cortex and that is the sensory cortex. So this is the first and foremost area to identify in tumors in this location. And once we know the central sulcus, then we start further mapping the motor areas. So we know that the motor homunculus has been described by Sir Walter Penfield. Is a pioneer who had described all these homunculus, and then he has started this type of mapping very, very early. But then it took time for this to come to reality into the OR. A lot of adjustment had to be done, and so that it can be done safely. And now we have quite sophisticated instruments to do that. So how we do the motor mapping? So motor mapping can be done either during the awake procedure or even during anesthesia. So when you're doing under anesthesia, it has to be lightened. Your relaxants has to be cut down to know that. So if you're doing an awake, you can know by the muscle twitching. And if you're doing in general anesthesia, you can do by your monitoring by EMG. So these are the ways which we can do. And there are basically two ways. You can either use a bipolar or a monopolar. So typically the Penfield technique uses a bipolar with a pulse phase of frequency of around 50 Hertz, with a pulse width, with an intensity and the duration of stimulus of 2 to 5 seconds. Then there is another technique using monopolar with Taguchi group, and it's more useful in pediatrics. and then they use monopocyle and that is useful for the pediatrics. And so you can see there are advantages of both, but we by and large use Penfield the bipolar techniques for motor cortex mapping, and this is the probe which we use. And so this is the company called Innomate, and we can see that. So this is the bipolar probe which we use, and we have everything. And what is the advantage of bipolar is that in bipolar it is a very focused area, so the current can pass between the two electrodes, ball electrodes, and the most important thing is it is biphasic. So what do you mean by biphasic is the electrode, the current switches the polarity between these two, so that there is no one particular point where there is a lot of current burning up. So that's advantages of, and so it avoids polarization. So polarization should be avoided because polarization causes the metal ions to move into the brain. It causes irritation. It causes seizure frequency. So, and then it also alters the electrical sensitivity of the surrounding structures. If you want to keep stimulating, then that comes as an interference. So by and large, we prefer a bipolar electrode with a biphasic pattern, which avoids polarization to have a optimum results with us. So now how do we do that in real time? So as I was mentioning you, so we have identified the central cell curve. So we know that, so the anteriorly is the motor cortex. As you see here, I'll just show this video. So we see there is a stitching. So we can see that when we are stitching the face, and we can see that the face area is getting stimulated here, and then we can see that the face stimulation. So this is an awake patient. So we can monitor where these areas are. So this is how we do. You can do. So we can do. So this is how we do. We also can do that using here. We can see the same thing can be done if it is an anesthesia. We can also identify this type of electrical signals, so we can know. So it is essential once we identify the central cell test, how subdivisions, how we do identify the motor, and so that we can avoid those areas in real time during the surgery. So now coming to this index case also, we can see that. So now we have identified the hand, the leg, and the face area. And intraoperatively also, we can identify them electrophysiologically. So that will give us a much better evaluation. Now coming to the subcortical mapping. So how important it is. So majority of the time, these tumors are quite large, and then the subcortical fibers come down. So we need to also know where the subcortical fibers are monitored. So it's equally important to map and also to monitor them so that you don't avoid damage to the corticospinal tracts. So again, so in motor cortex mapping, we use a bipolar, but wherein in a subcortical, we use a monopolar, as you see here. And the stimulation of the deep white matter that elicits a motor evoked potential, which propagates. So you can record it and then map it, monitor it. So these are the type of electrodes which you use. This is typically the suction probe. You can see that that's a ball electrical tip here, and it has an earthing wire, reference electrode, and the connector cable. So basically, when you're doing a surgery, you are having a suction in your left hand. So that can be used continuously. You need not do from the beginning itself. Because there is a risk of seizures. I'll tell you in the next slide. As we have mapped the area where it is, so once we know that we are going to near the cortex or sensory motor fibers, then only you start stimulating it rather than during the initial phase itself. So how do we do that? So typically, as I was mentioning you, continuous dynamic mapping, you start your electricity around 14 to 20 milliamps. So what is that 22 milliamps? Next slide. So you start with a higher current, and then as you near the corticospinal tracts, you come down. So there is a Coulomb's law which says that. So that means if you are able to stimulate at 5 milliamps, that means you are very close. You are almost close to 5 millimeters from the corticospinal tracts. If you are able to stimulate at 1 milliamps, that means you are almost on the motor fibers. So that is a rough calculation which we do. Generally, we stop around 5 milliamps. That is safer. And this is that I can see you. So when you're starting surgeries, so when you're close to the corticospinal tract, as you come down from here, you start reducing the current so that when you are stopped somewhere around 5 milliamps, you generally stop. You don't go nearer to 2 or 3 milliamps because you may sometimes injure the corticospinal fibers. So I'll just show you how we do this. As you see here, so this is the, you can see that the tumor is removed almost, and then we are coming closer to that. That is the suction probe. And we can see here, so as we're doing it, we are getting the stimulus. So generally at 5 milliamps, if we are able to stimulate, then we know that we are almost close. As you see here in this location, so these type of subcortical mapping and monitoring can help us during the surgery. So we can see here there's a baseline MEP, left and right you do, and then you start simulating at 50 milliamps, then you know that you are almost 15 millimeters away from the corticospinal tract. So when you come to 10 milliamps, then we are able to get response, then you're not getting response. That means you're safe, you can still continue to do start getting the response like this, then you know that you are almost 1 centimeter from your corticospinal tract. It can come down up to 5 millimeters, so that you are 5 millimeters close, and then probably we can stop the resection, because otherwise we'll be entering inside. So you do a baseline MEP, and then you do at the end of surgery final MEP, and make sure that. So even if a patient has some deficit, and if your MEPs are fine, you know that this patient is going to recover over the next few weeks. But what is the problem in motor and subcortical stimulation is one of the major disadvantages is seizures. Because you are instituting current directly on the motor cortex, very high risk of seizures. So one need to be aware of that. So generally 50 to 60 hertz strains lasting seconds are epileptogenic. And also current also can stimulate. So whenever you do this, you always instruct your floor nurse to have ice cold saline to get into the OR and then keep it on the table. So in addition to your drugs, immediately you have to instill cold saline, because that will abort your seizures. So whenever you're doing this motor mapping, motor stimulation, be better to have ice cold saline irrigation ready. For index case, we can see almost a complete resection using stimulation, and then you can see the post-op day. Actually, this patient had weakness, but then he improved post-surgery, because it has been, the motor fibers are displayed and you are able to decompress the tracts, and his gait has improved. So now various other cases, they are very, very useful. So as you see here, you can use all the modalities which available, whichever you have, something like fluorescein, and then you map central sulcus, and then you know that where it is. And so I'll just skip this video, but then you have multimodality, not about, you have anatomy by navigation, you have intraoperative fluorescence to identify them up, and also intraoperative urophysiology. So that actually helps in your surgical resection. Awake craniotomy is slightly something different from, the question can be asked whether with all the available modalities, whether you need to do awake procedures or you can do a GA with ION. So that is actually a matter of debate, because many times if you are using awake, the patient develops some weakness, you are forced to stop the surgery. Actually, it will be a transient which will recover, but you may have to stop the procedure, and oncologically it may not be very satisfying. So that is the group against doing awake. And because anyway, ultimately these patients are going to recover if your MEPs are normal. So if you have a good physiologist in your team, and then you are reliable, and then I think today, except maybe for language monitoring and mapping, for pure motor, there's actually no need to do awake. You can actually do with your anesthesia and ION. So this is one case where we can see that this is a tumor bang on the motor cortex. It's a surgeon himself, and then we did an awake procedure, and we see here that we started doing it, and as we went closer, he was awake, and when we started closing towards, we can see that we were 5 millimeters away with the stimulation, but he started developing weakness. So he was telling that he was not able to move his knee and then the foot. And then we waited for some time, irrigated with warm saline, waited, and then we resetted surgery. But then again, he started developing weakness. So we had to forcibly stop at one point of time. He was awake, he was a surgeon himself. So we tossed him, and then he told that probably we should stop because he does not have a deficit. So, and then, but ultimately, he made a good recovery. And then the tumor there was a small residual tumor here, but then this is a grade 3. And then he could receive adjuvant therapy. He's now almost 5.5 years, he's doing well. Again, similarly, a bang on the motor cortex. This is a young girl, and it was almost operated 9 years back. And at that point of time, she was the youngest in our country to undergo an awake procedure. And we can see that the fibers of the hand was lateral and the leg was medial. And then we can see that since she was a kid, we diverted her mind by giving the mobile, and she was playing video game. And then we were able to successfully do the procedure, and then she was quite cooperative, and we could see that we could almost achieve a good amount of tumor resection, and we can see that she could functionally become totally independent, and she could perform her program basically. And we can see she's even 5 years, 8 years follow-up, she's now grown, she's doing very well. And that time we published this because she was the youngest in our country. Now, subcortical stimulation is not only about the motor cortex, even it is much more useful as we go down the line into the subcortical white matter tumors, and that actually helps a lot. As you see here in this case, and this is a case just around the quadrate nucleus, and we can see that. So incorporating your anatomy and physiology is what makes these same surgeries very, very safe. We can see that these tumors are deep-seated. They're going almost around the motor cortex fibers, the corticospinal tract. So you mark the tumor with your navigation, and then you have anatomical landmarks, and then you have physiological landmarks here, and then you're able to achieve a good resection and with a good functional outcome like this. Again, tumors, we can see there's a large tumor around the centrum semioval corticospinal tract subcortical fibers, and we can see that the fibers are splayed around both anteriorly and posteriorly. So you have a very narrow corridor, and then you can see that the language is also coming up. So you have to choose the trajectory and deep. And so using your subcortical stimulation mapping, and then you choose the route, and then this is the postoperative. We can see that safely you could remove most of the tumor, and we can patient is recovered almost uneventfully. Again, a large tumors like this, you can see that there's a large pilocytic astrocytoma in a young child with a lot of cystic component above, and the entire corticospinal tracts are spread around the tumor, and we can see that both anterior and posterior. So we're giving, and thus cases, the subcortical mapping where you are is very, very going to be very useful. And then you mark the tumor, and then you can see that using a subcortical stimulation mapping, and we can see that the child getting response in 5 milliamps. So you can see actually could go up to 5 milliamps, and then you stop, and then you can see that the cell, and this is the post-operative MRI immediate. You can see that it's not stuff here, because if you stop at 5 milliamps, we go further. Then as you can see, very mild weakness of the arm, but that's recovered over a period of time. Again, even in deep-seated tumors like this, we can see that the corticospinal tracts are lateral. So you know where how to go. And then this is a baseline MEP. You start at 15 milliamps, and then you come down to 7, 5 milliamps. Then generally we stop at 5 milliamps, and then check. And then we can see that we use interhemispheric approach, especially when you're lateral, you start stimulating. When we are at 5 millimeters, we had to stop. Then there was a very tiny looking at the complications. As I was mentioning, seizures is one of the important complications one need to be aware of. Bite injuries are common, so proper bite. Otherwise, patient can develop significant tongue injuries when you are doing this mapping, especially MEPs. So that is important. Patient can move during surgery, so your current stimulation should be less. Your anesthesia communication should be very good. These patients are already fixed on the head clamp and not tolerated much. Elderly people, you should be careful about arrhythmias when you're giving large current, especially on those with pacemakers and cardiac already pre-existing arrhythmias. You need to be quite careful about. Now, what are the limitations of these techniques? As I was mentioning you, language we don't have, but that is beyond the scope of the discussion. IONM in very young children is quite challenging because pediatric population as such, the nervous system is immature, myelination is not adequate, and then so there are a lot of artifacts. So children is a different ball game altogether, and one need to be very careful about. And at this point of time, actually, we should be very, very thankful to this encapsulating, and has contributed a lot. And our late Professor Sandeep Chatterjee was one of the cornerstone pillars for developing this part of the specialty in our country. So to conclude, IONM is a very integral component in tumors in and around the Rolandic areas. It's not just about the mapping, it's also about the monitoring and prognostication. You should also know about the techniques properly and when to stop, what are the side effects and what are the complications. And communication is very, very important between anesthetist and physiologist, and you should be ready to accept the complications, provided if your physiology is good, you can prognosticate them and then counsel the family adequately. So thank you very much. I am okay for some questions.
Thank you, sir. There is only one question for you in the chat box. The question was whether we can do the can we map the central sulcus without the SSEP?
Without SSCPs. Actually, you can do direct cortical stimulation, provided you know where it is. But it will be worth, if it is deformed a lot, better to have a basic idea where your central sulcus, and then once you know that your motor cortex, then it is true. But Even otherwise you can do. Suppose if you're not exposed, if you're exposed to a limited craniotomy, you can do direct cortical stimulation and then look for responses.
Because nowadays, most of the surgeons are not plotting the SSCP to identify the central sulcus in the event of neuronavigation. Directly, they go for a direct cortical stimulation and then find out the motor cortex and go. What about this thing? Or still you prefer to put SSCP for all the cases?
One advantage is that I generally like to keep that electrode which we use for the SSCP, and even after the mapping, I leave it in place because it will help us to pick up the after discharges also epilepsy. So it's a worthwhile practice to do both SSCP and MEP, map the central sulcus and then do. But many times central sulcus mapping becomes a challenge. You may not be able to properly do. In which case we can do direct cortical stimulation. It's a matter of comfort, how you are. So especially. Only disadvantage is that if you are not exposed well, then you have to slide it underneath, and then with the risk of venous injury, venous infarct, if there is a injury to the venous system. If you're exposing a small area and if the navigation you're able to mark, then it is good enough, well enough. You can just do direct cortical stimulation and get to know the functional areas, motor areas.
One more question is, sir, do you do dynamic MEP mapping also, no? Do you do dynamic MEP mapping?
Absolutely.
So suppose in a direct cortical stimulation, you are getting around 4 milliamps the recordings. Then in what current you will keep it for the continuous MEP monitoring or dynamic MEP monitoring? You keep it at 4, or you just reduce it, or you just increase it?
No. When you are doing a dynamic, it's better to reduce it because continuous electrical stimulation also not good. So better to, if you are doing continuous, better to lower your current and watch. Because if you are using a high current, there is again a risk of seizures. And actually, if you, continuous monitoring has its own disadvantages also. So if you continuously use a large current, there is problem. So we have around 4 to 5, and then we keep around 2 to 3 for continuous recording.
Okay, sir. Thank you. Thank you for your time. And I'll call upon Dr. Sushant Kumar Sahu to talk on intraop neuromonitoring in insular glioma surgeries, strategies for maximizing safe resection.
Thank you, Professor Prabhuraj. And so my slides are visible now?
Yes, sir. Yes, sir.
Okay. And thank you, NSI, for giving us this opportunity to discuss various aspects of neuromonitoring. And so moving on to the next talk, it is on mostly for the insular glioma, the strategies for maximizing safe resection. So particularly for insular glioma, we need to discuss, I'll keep on discussing on why neuromonitoring is essential for insular glioma and what is the justification for a maximal resection in insular glioma, and then what are the different strategies for the functional assessment in insular glioma. So to begin with, actually insula is a deep-seated tumor, and if you look at these images, so surrounding insula, so many eloquent structures are there. The first speaker has already talked about like different modalities to identify on radiology. So in DTA or different imaging, if you can identify, there are a lot many functional areas surrounding the insula. So they may get affected during surgery, and that basically that forms the tumor brain interface mostly. So if you can map to this point, then probably you could able to like resect maximum amount of tumor, and already if those are affected by the tumor itself, then they need to be protected during surgery. So this is one study where we found that even if in insular glioma, majority of the patients are walking, talking, and absolutely okay with their profession, then when we did a detailed cognitive assessment, we found that majority of them are doing poor with the executive function, attention, language, and memory. And coming to speech, significant portion of this population has naming error. So if this deficit will already there before surgery, then this need to be the patient need to be assessed properly, and this forms for the post-operative assessment and post-operative like further evaluation of the patient. So by knowing all these like the tracks and what are the functional areas, it is not sufficient. These need to be mapped properly. These are the first insular glioma I did some 10 years back, and this is a young patient where the post-op radiology is completely okay and the tumor, maximum tumor is resected, but the patient was completely hemiplegic with aphagic. And even after 2 or 3 years of the post-operative period, the hand grip is almost like 10 to 20% and patient didn't improve. So probably we have the optimum idea about the peri-eloquent areas, but those times we could not able to identify those during surgery, or we could not able to map them properly. So this is another case where there is a large insular glioma coming up to the temporal parietal operculum, and the patient was operated with all these the standard techniques without any functional mapping. And look at this, what happened in the post-operative period. The patient landed with significant paresis, with significant compromise in the quality of life. So therefore, it is very essential that we should have like target to look for the functional assessment during surgery. So the oncofunctional balance is very essential in case of insular glioma surgery, and gross total excision is advised, but not at the cost of the functional deficit. So, what are the different strategies for functional assessment in insular glioma? The first step is for the identification of the peri-insular eloquent area or the networks, and then the different neuromonitoring modalities, how these can be monitored during surgery. So, coming to the first step is the identification of the peri-insular eloquent structures. So, different institute, different centers have their own protocol to identify what are the different areas. But recently, there are different the radiology is coming up, like functional MRI, connectomics are coming up. But the standard DTI is the basic to understand where the different eloquent structures around the insula. So very commonly we found that the corticospinal tract are pushed medially, and just lateral to them. In majority of the cases, we can find the inferior fronto-occipital fasciculus, and posteriorly we can identify other language tracts like the SLF and the arcuate fasciculus. So it is very important to identify these structures in the preoperative period, and to form a strategy how to map these structures during surgery and to protect these structures during surgery. So this is grossly what we do in all our cases. In all our cases, we divide in insular glioma. The first is the motor fibers, where the motor fibers are, particularly the corona radiata and the posterior and the internal capsule. Majority of the cases, it is pushed by the tumor most medially, and lateral to this, we get the IFOF. And if the tumor is coming up to the temporal opercular area, then ILF coming into the picture. Grossly, IFOF and ILF, and in addition to this, if it is necessary, if it is possible to identify the unseen fasciculus, these three forms the semantic pathway, and we apply all these armamentarium to identify the semantic error during surgery or to preserve these structures. Another important language pathway are the posteriorly and dorsally are the SLF3 and arcuate fasciculus. And with DTA, it is slightly difficult to differentiate these two structures, but combinedly we consider them as a single phonemic pathway. And during surgery, we try to identify if there is any phonemic error. So the main aim during surgery, the goal of mapping is to identify the functional boundaries. If anybody are interested, then they can go through this beautiful article by Professor Dufo. In this review article, he had mentioned about the functional mapping of all these structures. And in our center, we consider like two type of like stimulation paradigm for used in insular glioma. One is the low frequency, the bipolar stimulation or the Penfield technique, what Dr. Rupesh has already informed. There's a biphasic current 60 Hz, 1 millisecond, 1 to 4 milliampere. This is very fixed for the language mapping, and the threshold one decided, we keep it for the rest of the period of the surgery for language mapping. While going close to the motor area, the corticospinal area, as Dr. Rupesh already told, we also follow the same principle of a continuous monopolar stimulation or a suction stimulator method, where we start from a very amplitude and gradually come down. Although in awake cases, 1 milliampere equal to 1 millimeter may not apply, but grossly it can give you the if you are going close to the corticospinal tract. So the essential steps in insular glioma, we consider them in four steps. One is, the first step is the setting the current threshold, then identify the speech and language area in the cortex, then start debulking from the safe corridors, then to identify in the subcortical area if you can able to identify the functional boundaries. That will form the completion of the tumor resection. So in a bipolar, what we do is, if you keep the bipolar for 3 to 5 seconds on the cortex, it will produce as a temporary nerve block, and the action will be inhibited, and that will form we can identify the speech arrest. And if we gradually increase the current, then we can identify the current threshold with the bipolar current. So this is the basic of why we use a bipolar current in case of cortical mapping. So what are the tools we have now we are using for this assessment of this language are currently in our setup we are using the number counting, object or picture naming and dual task. Although pyramid and palm tree test forms a very like useful tool, but yet it has not been standardized in our country. So we basically we depend on the depending on the patient's like profession and the patient's like educational status and the family status, we form some like questionnaires, and those questionnaires will continuously be repeated during surgery to assess the language and the cognitive aspect during surgery. So with a simple number counting, but what we expect if the patient will count from from say 1 to 10, and with the direct electrical stimulation, there will be some hesitancy, delayed answering, or the speech arrest or hypophonia. So mostly we consider for the speech arrest to identify the threshold. And with the picture naming or the object naming, all the like language pathway, both the semantic and the phonemic errors can be identified. So the single task can be utilized to identify both of these. And this table, like the yellow color are the arcuate and the SLF are for the phonemic error, and the red IFOF and the ILF and uncinate are for the semantic errors. And these are the tests what we use in our day-to-day practice. And in addition, if the tumor is, we plan to resect from the frontal opercular area, we pay like attention to the frontal ascending tract to look for the like delayed initiation of the speech. And in that particular case, we use like the stoop test. In otherwise, we mostly rely on the object naming and the number counting. So this is just an example how to do a like a current threshold. So usually we start from 2 milliampere. Gradually we increase the current and keep the like bipolar stimulator for like stimulate from one point to the other. Do not like put the bipolar stimulator more than 3 times in a particular point. And where you get the speech arrest, that we consider as the threshold for the current stimulus. And once we get the current threshold, then this is fixed for the rest of the procedure. And the same current is used to map the language area. And the same bipolar also used once we are done, then we can use also to identify the inferior portion of the motor strip area. Like in this case, you can identify some twitching of the perioral area is found. So probably that forms the inferior portion of the motor area or the ventral premotor cortex. So this is what we get after the cortical stimulation. Once we do the cortical stimulation, then the language area is identified, the ventral premotor area is identified, and rest of the area we can choose for the safe corridor. In case of insular glioma, if you consider about the safe corridor, mostly we rely on the transopercular approach. Although only for very small insular glioma, we consider for the trans-Sylvian approach. Otherwise, in most of the cases in our day-to-day practice, we consider the transopercular approach. So it can be a frontal opercular if the tumor is coming up to the frontal opercular, or a temporal opercular. And for large tumors, we consider for the approach from both the opercular. So these are few of the examples. Like in the first case, the tumor is coming up to the frontal opercular and the Sylvian fissure is pushing down. So we consider the frontal opercular approach. And the second case, the tumor is pushing the Sylvian fissure up, and the majority of the tumor can be approached to the temporal opercular. And the third case, where the tumor is coming to the both area and the tumor is very large, then we need to approach these kind of cases with the approach from both the opercular. So if you consider from the frontal opercular, what I discussed previously in relation to the tracts and the different like eloquent area, another important structure will come up, that is the insertion of the frontal ascending tract to the frontal opercular. So while going close to those area, one should be very particular in assessing for the delayed initiation of the speech, or the speech arrest could be because of the stimulation from the frontal ascending tract, and that forms the another functional boundary in these kind of cases. So while stimulating like cases like in these, when the tumor is coming up to the temporal opercular, then we should consider about the ILF. And the test what I have already discussed about the ILF, those will come into the play while doing a subcortical resection. And for large tumors, of course, for the both frontal and temporal opercular approach, then during surgery, we need to assess and we need to get oriented where we are about the tracts while coming from both the frontal and temporal opercular. So for the subcortical stimulation, we have either we can stimulate the language area or we can look for the motor area. And directly for the motor area, we usually look in case of the right-sided and for the left-sided. And in both the cases, we look for the language area first. So once part of the tumor is resected, then the bipolar stimulation, and during the resection only, a continuous assessment is usually always done. Like the continuous assessment may be because with the picture naming, or a continuous stimulation with the dual task. If it is getting inhibited, and the surgeon should be like continuously like listen to the patient, what the patient is doing, and there should be a clear-cut coordination between the teamwork is very important. The surgeon and the neuroanesthesia or the neuromonitoring team who is looking after the patient, and what test is implemented, and what is the answer the patient is giving. So we have to be very particular about the semantic error, naming error, phonemic error, and there is delayed initiation of speech or some dysarthria or aphasia is happening. Then that forms the functional boundary. Like in these kind of cases, you can use the simple like the test which is available, like the simple things like the pain spectacles. Those can be shown to the patient, and to identify if the patient is able to identify them, the name them, or and in these kind of cases, you can also do a dual task to look for to differentiate between the motor and the language like combined inhibition. So with the simple test, we can identify semantic error, phonemic error, and other language dysfunction. So this is if you like use all these tests, like in this case of so like in this case of the large like insular glioma, where we approach from the frontal operculum, so we could able to resect almost majority of the tumor, and the post-operative radiology after 3 months, we did the DTI, and it showed almost the tracts are in position, and the posteriorly the dorsal language the tracts are just abutting the tumor resection cavity. So probably so intraoperatively we identify all these structures, and post-operatively it is also correlating where we are, and that forms the perfect the tumor brain interface. So this is what I have shown for the temporal opercula, and through the temporal opercula, once we are inside, then probably it is because of the like the semantic error that produced from the ILF or the and the IFOP that forms the boundary of the tumor brain interface or the language area, that is the for the functional boundaries in case of insular glioma. And a small amount of tumor or small residue can be like in future that can be just kept under observation or for adjuvant depending on the histopathology. So this is another case of a large insular glioma where both the frontal and temporal opercular are used, and the arrows are showing the areas where you get the language error. The orange arrow is showing like the from where we got the semantic like paraphasia, and the dorsal, and the yellow area is showing some naming error. That could be because from the stimulation from the ILF, or that could be like the inferior aspect of the dorsal language pathway. Both of them can cause some naming error, and that forms the functional boundary. And the post-op radiology was showing a good resection of the tumor. Only a small hyperintensity on flare is seen posteriorly, maybe in the zone 3, and that can be observed and that can be followed up. So this is another area where the this is very important. When we start resecting, purely we said we have resected the tumor from the insula, and we are like resecting the tumor in between the perforators from the MCA. And while we are going to the like into the depth, we most of the times use also monopolar current stimulation. With the monopolar current stimulation, you can see some stimulation directly from the upper and lower limb. That could be because of the directly from the motor pathway, or that may be from the corona radiata and the closeness of the this from the internal capsule, so that forms the functional boundary. So once this kind of resection is done, then in the postoperative period, if you do a radiology, you can find out where you are, and the postoperative images can be very nicely compared with these kind of images, where we could able to resect a good amount of tumor, and we could like reach up to these functional boundaries. So this is another case of a not a very large tumor, but left-sided insular glioma, which operated with the same principle of the cortical and the subcortical language mapping. And this is almost after 5 years, the patient is able to. He is a physician who is able to like perform his activities and nicely. And the post-op radiology is showing a slight hyperintensity over the insular area, and the patient is under follow-up without any adjuvant therapy in this case. So this is another example of using same cortical and subcortical language mapping that could able to allow us to resect maximum amount of tumor. And even after 4.5 years of surgery, the patient is able to like perform difficult like mathematical problems, and the patient is back to his professional life. So if it is possible, if you can do this kind of language mapping, even in case of large right-sided insular glioma also, these functional boundaries can be detected with this cortical and subcortical mapping, and it is possible to resect large tumors in case of right-sided insular glioma. In our center, majority of these times, both for the right and left-sided insular glioma, we consider awake surgery, because awake surgery only like allow us to do this kind of language mapping. So these are few other examples of large insular gliomas where we consider like operating through both the frontal and temporal opercula, and the postoperative radiology is showing very good resection with small hyperintensity, and the patients are under follow-up. So but this is not the same situation all the time. The flip side of this awake surgery and the language mapping is once the patient is like tired, if the patient is got fatigue, and if we are not getting proper stimulation, or like the very early period, we have gone up to these language pathways and we did some damage and the patient landed up with like some language deficit, then we'll have to believe on these like stimulation and we have to stop surgery. Like in this particular case, very in the very beginning, we have gone up to the depth, and there was some like the semantic error, maybe because of the like closeness to the IFOP, and that didn't get like recover during surgery. So we keep the patient for a redo surgery after after some 1 to 3 months in these kind of cases, and with the same parameters we operate, and we look for the maximum tumor, how much we can remove. But all the time, it is not possible to take out the entire tumor. And these kind of cases, we land up with like resecting, doing a subtotal resection if the patient is fatigued and the patient is having already some language deficit during surgery. So to conclude, intraoperative neuromonitoring and language mapping offers a direct assessment of the peritumoral functional areas, and it allows us to do a maximal safe resection in insular glioma. Thank you.
Thank you, Dr. Sushant, for his wonderful talk. We'll take the questions at the end. Now I call upon Dr. Edmund to talk about the deformity surgeries and the role of IONM in deformity correction. Because most of the surgeries which will use IONM will be of spine, and we'll just hear from Dr. Edmund what he's saying.
Good evening, everyone. Greetings from CMC Velo. I'd like to acknowledge NSI and Sion for giving this opportunity. Also like to extend regards to Charan and Bashir, neurophysiology team, the Sajid Thomas and Benjamin Srinivas Babu neuroanesthesia team, without which this work is incomplete. So we are dealing with the electrophysiological highway. As seen here, we are operating between the nerves, between the thecal sac, between the cord. So it is an electrophysiological highway, and we need to be careful when we are transitioning up from a wake-up test to a proactive real-time multimodal surveillance. We all know about the ascending and descending loop. We know that single modality leaves half the card in the dark. Hence, there is a necessity for a multidisciplinary collaboration, patient being the center, and an intervention between the neurophysiologist, anesthesiologist, and surgeon takes a paramount importance. And all have to know and all have to do the drill to understand the definitions of relevant signal change and eliminate hesitation during a crisis. And we see it's a triad of neural protection. So we are going between a surgical action and neurophysiological monitoring and anesthetic environment. And the paramount importance is to maintain the signal integrity. What are the core goals of monitoring in this case? It's a vigilance and mapping. We need to have an early detection, and we need to, once detected, we should have a precise localization as to how to overcome this. We all know neuromonitoring was introduced in 1972, SSCPs in 1972 by Nash, MEP by Merchant and Motor in 1980s, and over time, we have evolved into multimodal imaging. The modern IONM paradigm continues to be multimodal, and it is objective monitoring. And we have to know the anesthesia imperative in this. The halogenated agents and paralytics, they dampen the effect of IONM. The shift is towards TIVA that helps for having a good potentials. The spine cases, what are the modalities that has been used? We've been using SSCPs, MEPs, freerun EMG, D-wave, and now with high sensitivity and specificity, there's a shift towards multimodal monitoring. As we all know, SSCPs look for the dorsal columns, MEPs for the corticospinal tracts, and nerve roots by triggered EMGs and spontaneous EMGs, D-waves for the entire spinal cord. How does D-wave differ? They directly stimulate on record from the spinal cord. They are resistant to muscle relaxants, and it's a gold standard when you're dealing with intramedullary. The advantages of D-wave is there is an uninterrupted stability, and ischemic sensitivity is also recorded, and it has a high predictive value. Of late, there is a stress on necessity to do a pedicle screw staff safety guidelines. There's been necessity to do a spontaneous EMGs and also stimulated EMGs. In cases with a complex deformity, those with the rigid curves and those which has a tough degeneration and those which has a difficult coronal and sagittal imbalance, we prefer to use a stimulated EMG for placing our screws. So what are the high stakes that is associated with the deformity correction? We all know about scoliosis, kyphosis. I'd like to specifically mention about vertebral column resection and PSO. We all know the cord is at significant injury because of a mechanical insult. Already it is stretched or compressed. And there is a vascular insult because of ischemia due to the prolonged stretch. And there can be direct trauma when we are placing the pedicle screws. What are the consequences? It's a permanent neurological deficit. So there is a real-time safety net by IONM to mitigate these risks. As seen here, there can be a mechanical tension when the cord angle is severe, and surgical distracting maneuvers can stretch the cord. Vascular compromise because of inherent congestion can result in early deterioration if this is not picked up. What are the different? There are high stakes while you're doing the VCR. One, it could be due to pre-osteotomy phase. Second, during the decompression phase. And third, when you are stabilizing with the rods and screws. So this has been carefully looked at by the latest SRS guidelines from Praxis K pathway. We have to think that what is the high risk settings in OR. One, it can be attributed by the patient factors, those which have severe pre-op myelopathy and those which have poor physiological reserve. The pathological factors, as we are stressing on deformity, we would like to concentrate on deformity, and if there is ossified ligaments and stenosis, and surgical factors, the corrective maneuvers, long osteotomies, prolonged surgeries, high blood loss, which can result in hypotension. So what are the 5 phases? What is the prevention and response? First, do the initial assessment, have a pre-op planning, have a surgical plan ready, anesthesia plan ready, intra-op management, and post-op management. So whenever you have a drop in IONM and whenever you have a neuro deficit that is expected, what needs to be done? So the SRN's guidelines defines that whichever is the high risk, in case of high risk correction and tumor and stenosis, go for a pause and response protocol. So as we know, the SSCP alert when greater than 50% reduction, MEP alert more than 50%. What do we need to do? First, you need to stop, pause the maneuver, the corrective measurement that needs to be done, and announce that there is a drop in the IONM from the neurophysiology team. Check if the electrodes are placed properly and the depth of anesthesia. Go for hemodynamic augmentation, transfuse blood, increase the pressure, raise the map, reverse the corrections that you have done before, remove the pedicle screw if that is causing the defect, and correct the temperature hypothermic and also alter your signals. And once you have done this, you have to reassess. And if required, we can do a wake-up test, but that's not required in the current setting. And also look in the room if there are any problems and if there are any noises. And also look regarding the anesthesia, ensure regarding the map and surgical reversals as mentioned before. So this topic of discussion today is about VCR. It's a complex surgery that helps us to maintain the balance and correct the kyphosis. The indications include predominantly deformity correction, and it could be infective, or it could be trauma related, or it could be tumor related. It is technically demanding and it has increased operative time and increased blood loss. There's risk of paraplegia and paresis. It was first introduced by Macklin in 1922, popularized by Suk et al. By a posterior-based approach. The steps, as described by Lawrence Lenke, includes placement of the screws, correction of the deformity, bilateral facetectomy, bilateral laminectomy. Then you go for pedicle subtraction osteotomy, remove the deformity correction, and then cage insertion and bilateral placement of the rods. This would be enumerated in the step. This is a 53-year-old lady who presented with 2 years history of trauma with progressive myelopathy. She was Nuric 3 at presentation and a Cobb angle more than 55 at presentation. And she was spastic. So as seen here, we have placed all the pedicle screws. So it's always good to have two hands simultaneously, the screws being put, two senior persons scrubbing up as it's a long case. Do the corrective laminectomy. In each step, ensure you're having a continuous MEP that's done. So the rod has been placed on the opposite side through a lateral approach. We are reaching to the ventral aspect of the deformity. The bone has been removed. The root has been transected. The part of the bone which is impinging the cord has been pushed down. Gentle retraction of the cord. As you can see, there's extensive blood loss. Cage is being deployed. And continuous monitoring when the cage is being pushed towards the center. Please note the rod that has been placed to secure it. A final confirmation and check. Patient did well after the surgery. This is an example where sometimes you cannot use the cage. You have to use local autograft. This is a patient who underwent a deformity correction for a tuberculosis, where we have placed an iliac bone graft, and follow-up check X-ray done after 3 years shows it in good position. Patient has improved from NURIC 5 to NURIC 3. This is a patient who had been operated elsewhere, who had come to us with severe back pain. Patient was bed rest, and patient has come to wheelchair after the surgery. As seen here, definitely there is a failure of the previous surgery. There is increase in the vacuum phenomenon, and there is severe deformity, and there's a loss of coronal and sagittal balance. However, the previous screws have also loosened, and there's a hollow sign. Hence, we have planned for increasing the level of the implant and to correct this deformity. So this poses a great surgical risk because the patient had normal power before surgery and she was NURIC 1. So this is the MRI showing severe canal stenosis. So long level exposure, the previous implant has been removed. The rod has been placed. Bilateral facets have been removed. You can see how the thecal sac is compressed by the severe compression and the deformity, and the cord is literally squished between the two bones. After laminectomy and vasectomy, we were able to make the progress. Then continuously, we were monitoring to ensure there is no deficit. And this is the final picture. We're connected by the dominoes, baseline, and after exposure screw placement in end rod. And this is the final picture. Patient is happy at follow-up. So the most important thing is to have a multimodal imaging and multimodal monitoring in order to reduce the deficit. In our study, which included, it was a retrospective study, we looked at the last 8 years. We had almost 53 patients undergoing this deformity correction. It's a single stage or a double stage, both were included. We had thoracic and lumbar. And the pre-op NURIC 5 was almost close to 60%, those with poor grade NURIC 4 and NURIC 5. Predominantly, our series comprised of thoracic. We had 47 thoracic corrections and 6 lumbar with a good median follow-up. And in those patients with the Nuric 5, we had a significant improvement. Almost all of them improved to almost 80% of what had improved in the infective group from Nuric 5 to Nuric 3. And 60% of the patients were independent of for their ambulations. And the positively, what we have noticed is those with an infective etiology have demonstrated good postoperative improvement. The mean Nuric recovery rate was close to 43%. P-value was significant. There were 9 non-responders, and because of this constant increased ISI changes, increased signal intensity changes in the cord, which has contributed to it. Our alarm card criteria has been in what has been described in the literature, and the same measures were taken whenever we had come across the alert. And this is a classical example to demonstrate true positive, and false negative and true negative has been defined as what has been described in literature. And out of these patients, out of 53, we could do MAP monitoring only for 20 patients because they were of a good Nuric grade. And we had 12 positive IONM alerts, of which positive change, that significant improvement was seen in 9. We had 3 in which there was a post-op deficit in 1, which was a true positive. And that patient continued to be have a deficit, permanent deficit, even at follow-up. And 2 patients had false positive deficits, and they were good at long-term follow-up. Negative INM alert was seen in 8. This study demonstrated the sensitivity and specificity of MEPs to be of 180% respectivity. We had false positive rates of close to 10%. Younger age and multiple levels operated was significantly associated with increased IONM alerts. This is in line with what has been described in the previously in literature by Lenke and Sala et al. And they also noted that young patients, particularly those with congenital and severe kyphotic deformities, they exhibit a lot of fluctuations during the surgery because of reduced canal diameter, stiff curves, and limited compensatory reserve. So we have to press towards multimodal IONM monitoring both MEP and SSAPs. We are in process of change, and it's important to incorporate D-wave when you are doing the complex intramedullary tumors, but that's beyond the scope of the discussion today. And whenever you have an early warning signals, you need to know that these are the reversible cord distress. So you have to make the corrective measures, temporary release of distraction, blood pressure optimization, stage correction that will help you to have a safe spine surgery. The way forward is to have an AI incorporated to help us detect what are the standardized alert protocols, machine learning integration, and predictive analysis. Key takeaways from this talk: multimodal is the way to move forward. We are in the process of adopting to a multimodal modalities of image monitoring. And TIVA is the gold standard as described. And you need to have a checklist. And then you need to have each member of your team should be on the same page. And we all know the signals predict the future. So beyond preventing paraplegia, sustained intraoperative signal improvement is a real-time prognosticator in patients with functional recovery in myelopathic patients. Thank you for the time.
Thank you, Dr. Edmund, for the wonderful talk. So now we'll go for the Dr. Vishaka. So she'll be talking on IONM for pediatric patients and a special interest on spinal dystrophism.
Is my slide visible, sir?
Yeah, you can go on.
Yeah.
It is visible.
Yes. Thank you, NSI, for giving this opportunity. So we have already seen a lot of, there are, okay. So all the adult neurosurgical, all the INM techniques which are used in adult neurosurgical neurosurgeries can be used in pediatric neurosurgery, but it has few challenges, and there are few pitfalls and limitations. So objective of today's talk is to understand what are the common pitfalls in intraoperative monitoring in children, discuss the practical strategies to navigate those pitfalls, and some strategies specific for intraoperative monitoring in spinal dystrophism. As we all know, the purpose of intraoperative monitoring is to detect ongoing damage, halt the damage, to predict the neurological outcome, and to document it. So various techniques, we are all aware of it. Monitoring technique, usually they give us continuous assessment of the functional integrity. It identifies ongoing advertent damage, still when the damage is still reversible. And the examples being MEPs, SSCPs, D waves, bulbocavernous reflex, and free running EMGs. Mapping techniques, they identify the functional areas or roots within the ambiguous neural structures, and the example being mapping of the floor of the fourth ventricle or mapping of the chorda equina. So what are the pitfalls in intraoperative monitoring in children? Specifically because the children have the brain and all the neural structures are still immature, so there are neurophysiological pitfalls, technical, anesthetic, physiological and systemic factors, and surgical and clinical factors as pitfalls. So first, let us go what are the pitfalls in each technique. So in motor evoked potential, as we all know, it can be monitoring and again mapping techniques. So monitoring techniques, it can be single wave stimulating technique, we call it as D wave, or multiple pulse stimulating technique, we call it as MEP. And mapping techniques, direct cortical stimulation for mapping. So for MEP, we usually take C1 and C2 montage. Rarely, sometimes for lower extremities, CZ-1 or CZ+1 montage is taken because it gives less body jerks. Lateral stimulating montages are avoided in children because they give more. They do stimulate the corticospinal tract a little more deeper and might induce vigorous jerks. If there is a possibility of using direct cortical stimulation, it is better to use, for example, in supratentorial surgery, because the intensity of the current needed is almost 10 times lower as compared to the transcranial MEPs. So what are the pitfalls because of immaturity? Are because of incomplete myelination. There'll be difficulty in acquiring the MEPs. It again, because of immature synaptic transmission also, sometimes it will be difficult to get MEPs. So we'll just go little deep dive into this. Actually, if we see by 40 weeks post-conception, the corticoneural connections, they reach sacral levels by 40 weeks only. But the myelination starts after that and it continues up to 1 to 2 years. And the neurophysiological maturation of corticospinal tract progresses through childhood and adolescence. So there is a discrepancy between the anatomical and neurophysiological development in the corticospinal tract. And that is why the MEPs may not be elicitable, or we need higher stimulating threshold to elicit MEPs. And this is very well seen in many papers. Here in this graph, you can see there is higher trend of stimulation intensity need for the younger children. Also, but because of sometimes thinner thickness of the skull, which leads to lower impedance, it can counterbalance the higher need of threshold to elicit MEPs up to a certain extent. So to overcome the immaturity of the neural structures, we have to use multi-pulse high-intensity stimulation, because high intensity can go a little more deeper in the brain, and which can overcome the lack of myelination. And a train of desynchronized stimuli can increase the spatiotemporal summation and will help us to elicit the MEP. So the another pitfall is sometimes the MEPs can be unobtainable because also discrepancy between anatomical neurophysiological development of the peripheral nerves, because the maturation of the peripheral nerves takes around 2 to 3 years to complete. The next pitfall is because of improper selection of the muscles with a poor corticospinal tract innervation. So if we use proximal muscle, we may not get good MEPs. So it is recommended to use small hand muscles, abductor pollicis brevis, and long forearm flexors and extensor for upper limb, and abductor hallucis brevis and tibialis anterior for lower limbs. The next pitfall is because of sensitivity of MEPs to environmental factors like room temperature, immaturity pathway, and the various anesthesiological factors. So it is always recommended to keep a control. So for example, if you're doing transcranial surgery, for a tumor. So it is important also to monitor the ipsilateral abductor pollicis brevis and median nerve SCPs as control along with the contralateral, because if there is a generalized lowering of the MEPs because of the anesthesia factors, we can rule out a neurological injury. And for spinal cord, similarly for spinal cord injury, below cervical enlargement, monitoring of the SCPs and MEPs is important from at least one upper extremity. The next pitfall is interpretation of alerts in young children. So this can occur because of there is also inherent MEP amplitude variability in children. So whenever we get some abnormal values, we have to see whether it is obvious, whether it is consistent, whether and it is clearly in excess of ongoing variable results. So and that is why there is a different criteria for brain and spinal cord surgery. So for spinal cord surgery, as long as we are monitoring D wave, then and the D wave amplitudes are more than 50% baseline, the all and none criteria for MEPs can be done. But if there is no D wave monitoring, most of the times we take more than 50% drop as an alarm criteria. Whereas in brain surgery, avoid more than 75 to 80% drop in MEPs have to be avoided. So now coming to the next modality is D-wave. D-wave are actually extremely robust for under general anesthesia because they are generated by synaptic pathways and they're less affected by environmental factors. So they are actually better for children, but the monitorability rate in young children is less than 20 months. So this is because of again immaturity of the tracts, there is desynchronization and no wave formation. Coming to mapping techniques, these are almost similar to what is used in adult. Only the difference is Penfield technique is not much recommended due to high incidence of seizures, as already told by our senior speaker. And most of the time, short train technique with monopolar is used. Coming to language mapping, awake surgery in children can be done from the age of 11 onwards, but less than 11 years old children is difficult because they are uncooperative. So few papers have suggested two-stage operation surgeries, like they implant a subdural grid electrodes at the first surgery. Then they do extra operative recording once the child recovers from first surgery, and then followed by the final surgical resection. But I don't have experience in that. So the next modality is SSEP and phase reversal technique. It has already been covered by the previous speaker. I just want to highlight that the intensity range, stimulation ranges we have in children should be from 20 to 40 milliamperes. And we record usually from CZ to FZ for lower extremity and C3, C4 to CZ for upper extremity. And it is very important because sometimes because of the immaturities, we may not get MEPs. So SSCP monitoring is very important in children as well. So next modality is monitoring and mapping techniques in infratentorial surgery. We all know that infratentorial tumors are more common in children. So it is a very useful technique, and it warns the surgeon when the injury, when there is an impending injury, especially because of coagulation and traction injuries. So we can do here mapping of the fourth ventricular floor and some monitoring techniques like MEPs, the corticobulbar MEPs, and then BERA and SSEPs. So important point here is stimulation intensity. Again, it should never go beyond 2 milliamperes for mapping, and initially start with 0.5 milliampere, then screen the area, and whenever we are sure that we are coming to the particular nuclei, then we have to reduce it to the threshold intensity. So next major pitfall is anesthesia techniques. So we have to always, whenever we want to do intraoperative monitoring in children, we always have to talk to anesthetist, and the anesthetist should be very much trained and experienced for that. And many papers have suggested either partial TIVA or total TIVA anesthesia. So anesthetic agents like volatile agents should be avoided because they suppress SSP and MEPs. Propofol and etomidate can be used, and especially EMGs are not affected by any drug, so it's important mainly for MEPs and SSEPs. So our protocol is we usually induce with propofol and fentanyl. and then rocuronium is given. So after intubation, there will be continuous TOF monitoring, and we confirm the absence of muscle relaxation before mapping and monitoring by TOF monitoring, and then it is all maintained by sevoflurane inhalational anesthesia. It is very important to always monitor the depth of the anesthesia with BIS monitoring, use bite blocks to avoid tongue bites, and strict maintenance of there should be no hypotension, no hypoxemia, hypothermia, or anemia. And boluses of anesthetic drugs should be avoided. This is the setup. So the next issues will be technical, because not in all cases we can use a corkscrew electrodes for children, because sometimes AF might be open or weepish, and in those cases, cup or needle electrode should be used. So now coming to intraoperative monitoring in specific to spinal dysraphism. So why it is needed in tethered cord surgeries? Because first thing, all the tethered cord surgeries are prophylactic surgeries and almost offered in all asymptomatic cases. So we have to avoid the neurological deficit. Second thing, sometimes, for example, in spinal lipomas, the total removal will give better outcomes. And that is why we have to aim at total removal. And without intraoperative monitoring, we cannot, there'll be high risk of neurological damage. And the risk of permanent neurological complications is almost up to 4.5% if in these surgeries. So it's important to use it to avoid the injury. So the especially what we use in spinal dysraphism, the mapping techniques, as I already mentioned, it is to map the chordic vena, and it is very important because to identify and cut the functional nerve root. So before we cut any abnormal band or any vestigial root, we have to see whether it is functioning or not. And also, once we have already mapped the chordic vena, we can very well cut those. So cut the vestigial roots or the bands. Another technique, the other important techniques will be monitoring techniques. So monitoring techniques always assess the functional integrity while during ongoing surgery. So the examples being we use MEPs from limbs and even anal sphincter MEPs, SSEPs, and bulbocavernous reflexes. These are all these, and also free running EMGs. So monitoring and mapping of chordic vena, as I already mentioned, this is anal M wave. M wave is created when we directly stimulate by triggered EMG. Anal MEP by transcranial stimulation. Bulbocavernous reflex when the pudendal nerve is stimulated, and then there'll be a contraction of the anal sphincter, that is bulbocavernous reflex. But it is not always possible to elicit and perform bulbocavernous reflex in children. But if we are able to do it, then presence of the response after the surgery predicts good bowel and bowel function. So there are various papers have emphasized the role of to minimize the risk of neurological deterioration using the intraoperative monitoring. And because the deficit without monitoring can be as high as 15%. So this is just example of MEP monitoring for a case of spinal lipoma. This is during resection of the lipoma, reduced MEP is in tibialis anterior. So we had stopped at that level. So it is very important that if there is a loss of muscle MEPs in chorda or conus, surgery indicates that there's a complete lower motor neuron lesion and postoperative motor deficit with presumably little tendency to recover. So it is very important if we have a fall in MEPs, first that can take it as a alarm criteria and then check everything and the level of anesthesia, hypotension, hypoxia, everything, correct it. And even if it is persisting, then we have to stop the surgery. The mapping techniques, as I was just mentioning, and this is mapping of the chordic vena. And as I said, sometimes there might be nerve roots attached to the phylum terminal also. But once we have done the chordic vena mapping, then we can also sacrifice that. Now coming to there is a lot of debate whether to do or not, whether MEPs can be done in less than 3 months old babies. So this is a paper by Dasling Pang, who said that it is safer to do transcranial MEPs in all children in all and with the minimum effective voltage and safely. So in our data, we have done almost 10 cases in less than 3 months age from 2020 to 25. This is MEP response in 20 days old child with thoracic MMC, and we could elicit it, and then some MEPs improved after surgery. The technical nuances to improve the monitorability because MEPs sometimes can be absent before and then can be improved after excision of the surgery. But then clinical correlation is doubtful. Sometimes in younger babies, we might get only MEPs on one side, and other side we did not get the MEP. So that time we can try interchanging the anode and cathode. So we did it here, and then we started getting MEPs on right side also, and then thus we can keep monitoring it. So this is a case where there were 10 months old baby with a transitional lipoma. This is after durotomy, and there was the MEPs reduced during excision. Even that time, even after all checks were done, the MEPs did not improve. But this was a false positive because after I had stopped the surgery, we reversed the child, but child was neurologically completely intact. So what is the message here is we have to always keep a control. We did not keep a control at that time. We should have done also in upper limb, and then we might have gone ahead if the upper limb MEPs were normal. So the pitfalls in alarm criteria. So because there are a lot of because only one modality we cannot take. So we have that is why decrease in MEP amplitudes should be checked along with the prolonged along with the EMG findings. So the modified MEP criteria is given by Kim et al. And they say that MEP law decrease in MEP 70 to 80% along with loss in waveform and or a stimulation threshold increase exceeding 100 volts. So and SSCP criteria more than 50% drop in SSCPs. So as I was just mentioning, limitation of each, if we use only one technique, then there will be a lot of limitations because different only SSCPs are much affected by MEPs. But then when MEPs are not elicitable, SSCPs can be checked. Even similar with the free running EMG also can help us. And so these are the alarm criteria. These are the algorithm. When we get some alarm, then when there is a significant alarm, stop the surgical step, irrigate it, and check for depth of anesthesia, check for MEP, check for hypothermia, check for hypoxemia, and check for hematocrit also. Correct all the factors, check for consistent loss of MEP after 10 minutes again, and then check for any technical issues like intensity, duration, and repetition rate, and check for surgical issues like we have to see whether there is a deformed anatomy, and then again try repeat with repetitive incremental stimuli. If still there is no response, then stop it. If MEP improves, then continue it. So to conclude, intraoperative neuromonitoring is an efficient tool for improved outcomes in pediatric neurosurgery, along with good surgical technique. And multimodality monitoring, both motor and sensory, will improve the efficacy and improves outcomes to avoid pitfalls. All techniques of intraoperative monitoring used in adult surgery can be used in children except awake surgery with some modification in techniques. And in spinal dysraphism, MEP has a strong predictive value, and MEPs can be monitored even in very young patients also. This is of course a team effort of neurosurgeon, neuroanesthetist, and neurophysiologist. Thank you.
Thank you, Dr. Vishaka. We'll be going to the last speaker. We welcome Professor Med Kathleen Sable, President of ISIN, to give a talk on intraoperative monitoring in spinal cord tumors and the recent advances in the spinal cord tumor monitoring.
So, hello everyone. Can you hear me very well?
Yes, madam. Yes, madam. Can go ahead.
Yes, and you see the presentation slides, right? In the
Yes.
presentation mode. Perfect. So thank you very much for inviting me to your wonderful webinar. There has been a lot of things already explained and said, and it's always exciting to listen also to the lectures of the other participants. And if you look to India, just for sure, we have to highlight Dr. Sandip Chatterjee, because I think he had a great impact, right? So if it comes like comparing to the years in 2017 and 18 when he started like these IOM meetings in a small room with maybe 30 or 50 participants, and then like just comparing this to the last ScienCon meeting in 2025 where you had almost 650 participants, I think this is quite impressive. So when we talk about mapping and monitoring during intramedullary, and I also will add a little bit extramedullary tumors, we have to have a concept or a plan. So what should we talk about? So one is the surgical strategy for sure, because we want to take the tumor out. But there's also a neurophysiological strategy. So what do we need to monitor and what do we need to protect? For sure, there's an oncological strategy, because at the end, maybe both the surgical and the neurophysiological strategy will change related to the histopathology. And then for sure, we are all in the operating room because it's a functional outcome of our patients. And the question which I also want to add a little bit, because you have the great opportunity to contribute in your country, is there any evidence for IOM? So when it comes to the spinal cord, to be honest, when we have to ask ourselves, what can we measure? It's not so much, because we can neurophysiologically observe the dorsal column, which are reflected by the SCPs, and we can monitor for sure the anterolateral column, so the cortical spinal tract mostly, which is represented by the MEPs and the D wave. So if it comes to extramedullary lesions, I just want to go like in high-risk procedures. And this is sometimes this anterior calcified meningiomas, right? And as neurosurgeons, we sometimes approach them a little bit different than orthopedic surgeons. So we would come from behind. And if you come from behind, maybe really IOM will make an impact, because you really have to manipulate the cord. So especially if you're going away a little bit from this laminectomy to hemilaminectomy, which is more going all this direction of minimal invasive approaches, then yes, you can do this, but then you have to cut the dentate ligament, right? To come to the lesion anterior. Doesn't matter if this is a tumor or if this is a intracranial hypotension, like a leakage. But you have to approach this anterior aspect. And then to approach it, you have to rotate the cord. And I think here IOM plays an important role, even if the lesion is extramedullary, because you want to see the integrity of the pathways, so SCP, MEP, and maybe D wave. So coming to the question, and I just added this, is there any evidence? Because when I was in the ScienCon meeting last year, I had with several groups these discussions. What could you, especially from India, contribute to the literature for IOM? And one for sure is developing new techniques, but the second is like creating evidence. Because you are in the setting where you have like a lot of centers and where you perform IOM, and a lot of centers where you don't perform IOM. And maybe within the same center, you will perform sometimes IOM and sometimes not, accordingly to the availability of the IOM team. So we had the same situation for these meningioma cases. So when we do surgery on those, we would love to have IOM, but if we need the IOM teams for, let's say, supratentorial surgeries or skull-based surgeries, sometimes these are the cases, to be honest, which are a little bit left behind, and we say, okay, then let's do them without IOM, even in our center. And then we were looking in a retrospective registry for our data, and it was 86 patients, and 35 of them had no IOM, and 50 had IOM. So you might argue that more complex cases were still like put in the IOM group. So you delay the surgery, you wait until IOM is available, and maybe the more easier ones would go without IOM. But if we checked in our cohort, honestly, the contribution was equally. So anterior lesions, calcified lesions, lesions which took the whole spinal canal almost, patients with preoperative deficits. So like looking in this small cohort, the contribution of the severity or the complexity of the cases were similar in the no IOM group and in the IOM group. Luckily, performing surgery, all cohorts improved. The patient benefited from their surgery. But what is interesting for us is, like, do we see a difference after the surgery in the IOM group versus the no IOM group? So to be honest, just looking at the numbers, there was no statistical difference. And maybe the problem is because this is a study which is heavily underpowered, because we didn't have enough cases, but you have this opportunity. But looking in the detail, just making reasons of our data, we could see in the no IOM group, we had 3 patients with neurological deficits directly after surgery, and 2 who had a persistent deficit at the follow-up consultation. In the IOM group, we had 1 patient with a deficit after surgery, but no one in the follow-up. So again, no statistical difference, but we saw a tendency that IOM might help, even if the cases are equally contributed, to get a better outcome. And for sure, if we really want to discuss this in the world and creating evidence, we need a multi-center studies, we need more centers to contribute. And one possibility is the Spine Tango initiative. So this is coming out from Switzerland, but now accepted by the European Spine Society, and from the ISIN we have a cooperation. So this is a registry for spine and spinal cord surgery. And if you're interested, you can scan the QR code, and it will lead you to the ISIN webpage, because what we did from our side, adding to this big registry, we added a sheet for IOM. So you have to put the surgical data, you have to put the demographic data, but the IOM team, whoever performs it, and this is also part of the questionnaire, has to add the IOM information. And what we hope is to generate more data to compare, do we get a benefit if there's IOM, and especially in which cases we get a benefit, and maybe in which we don't get so much benefit. And then for sure, maybe a little bit more rare disease for sure, but still very important are the intramedullary cases, right? And then if we talk about intramedullary spinal cord tumors, for sure we have to highlight many people who contributed from the neurophysiological perspective, so Professor Vetrandelatis and Vaher Massen, but also from the surgical perspective, who are Fred Epstein and Karl Kotbauer, to improve the field. And you're all familiar with D-wave monitoring, and we know it's an excellent marker for the long-term motor outcome. So if the D-wave is preserved, the patient will be neurological, motor-wise intact in the long term. And if we lose the D-wave, or if we get a significant decrement of the D-wave, mostly 50%, we have a long-term motor problem. So yes, we all know this, we stimulate the motor cortex and we record distal in the spinal cord. And again, coming to the evidence, and does it really help? Because sometimes this is something you have also to justify in front of your hospital administration or your government or patient societies. I think an important paper is this from Francesco Sala in the Verona group. So he was a young resident or fellow. He was sent to New York by his senior surgeon, and he came back and he introduced IOM in Verona. So the surgeon was already very good. He was excellent. He was, let's say, in the horizon or senate of his expertise. But then he said, okay, bring back IOM. And he did bring back IOM, especially D-wave monitoring. And then later they did a retrospective historical control study, and they compared the two groups where they had no IOM, but already a very experienced surgeon, and now IOM, and again a very experienced surgeon. And what they could see, that IOM did make a difference, a significant difference for the long-term motor outcome in the ependymoma group. And especially in those patients who were like moderate impaired, not the very heavily impaired and not the very healthy ones, but the ones which are like the patients we mostly do surgery. And then if it comes to D-wave monitoring, I just want to introduce a little concept from our group. So we learned this from the publication from Paola Costa from Italy and Veteran Delators. So there is a technique which is called the anti-D wave. So what you could do is also you stimulate from your spinal cord catheter, and you record proximal from your corkscrews you already use for the SCPs. And then for sure you get a late potential, which is like the SCP elicited by the spinal cord. But you also get a first peak, a spiky peak, which is called the anti-D wave. And this peak maybe help also in the future to predict outcome and also help in mapping. But again, there's a long way to go. So if we talk about intramedullary tumors from the surgical perspective, it's important to understand that we have to discuss, are we talking about those guys or those guys? Because the left-sided are ones that have a good resection plane, so those are the ependymoma, and the other ones are the infiltrative ones, which are more the astrocytomas. And for sure, as a surgeon, it matters what surgical plane you have, because the upper ones are a little bit more easy to resect than the others. So if you come and you want to access those tumors, the question is where to cut in the cord, because we know the cord is super small, and if we cut exactly in the highway, as the previous speakers have discussed, we are in problem. There are many approaches described. One is like the midline approach, so you go between the both dorsal columns. Then we have the DRES, the dorsal root entry zone approach. And then we have the approach just anterior to the dentate ligament, because this is just anterior to the cortical spinal shaft. So these three entry zones are described. However, if we have a tumor, we have to understand that the anatomy of the cord can be distorted. And then it's essential to have neurophysiology to guide us to understand where we can cut and where not. So for sure, what we don't want is if we cut dorsally and then we lose both side SCPs, because we're always looking at MEPs and they're super essential, but the patient who has injured the dorsal columns on both sides will not work because he's missing the proprioceptive feedback. So there is a beautiful technique described by Mirella Simon from Harvard. And what she did is like to introduce the concept where you stimulate the cord with a probe, bipolar concentric probe, with an SCP paradigm, and you record the phase reversal of the SCP via your corkscrew electrodes. And that way, you can define your neurophysiological midline. And then once you entered, you have to find your plane as a surgeon. You maybe debulk the tumors, especially if the bigger one. And then maybe it's helpful if you can understand also where the cortical spinal tract is running. And we developed the technique together with Veteran Delators and also Karl Grotbauer where we use the double stimulation paradigm to identify the cortical spinal tract and the dorsal column, using the recovery time between the two trains to understand which is sensory and which is motor. So the idea is, if you stimulate a sensory structure, you get a response after your first train of stimulation, but because it's a sensory structure and there are multiple synapses in between the central activated H reflex, you will not convey a motor response if the synapse is still blocked. But if you give this paradigm with a double train, for the cortical spinal tract, for a motor structure, you're only in the output, so you don't have a synapse in between. So both trains will generate a response. And that way, you can map within the cord to identify, let's say, real motor structures. Because for sure, if you stimulate in the cord and you just look for motor responses, there will be a lot, because like if you cut the head of the chicken is still running, right? Because there are a lot of central pattern generators and a lot of reflexes. But maybe we want to understand which are the true cortical spinal tract related fibers. And those are the ones who give you the double response. And we have done this in a very small cohort of pediatric patients. We used the technique, and this is the MRI of a pilocytic astrocytoma at the cervical cord, and you see it crosses the midline. And we used the mapping technique, so identifying sensory structures on the dorsal column and also the cortical spinal tract inside the resection cavity. And the post-op MRI you see below, and you see there's an almost complete resection with a little remnant at the level of the spinal cord artery and the pilocytic astrocytoma in the histopathology. And this is a child 1 month after the surgery, and the parents did send us this video to show. And what you can see is that he has an intact cortical spinal tract, but also an intact dorsal column, because she can walk in the water. But you also see she has a weakness of the alpha motor neurons on the left hand. On the right hand, she's super fine. And I think it was possible only because of neurophysiology. So coming also to the talk of my previous speaker, I just want to go a little bit also to lipoma surgery. And this is also very complex cases depending on the location of the lipoma. But we were wondering, sometimes might be there the case that we would sacrifice a sensory route to get a better detethering, but we don't want to sacrifice a motor route. So the question is, can you neurophysiologically differentiate between these two routes, motor and sensory? Because the anatomy in these cases is totally distorted. So what we did is we did use, again, the stimulation paradigm. Just coming back a little bit, you would say, okay, I stimulate a sensory route like on the left side, and then for sure I get a response, which is a little bit longer in the latency and a little bit smaller in the amplitude, because it's a posterior root muscle reflex. It's the neurophysiological correlate to the tendon reflex, right? So you stimulate the sensory route, you have the synapses who give you the H reflex, and you get a motor response. Smaller, longer latency, compared if you would stimulate the anterior route, which gives you a high response because it's a good excitation and a short latency response. However, if you have this lipoma influencing your motor route, or also you would have a schwannoma influencing your motor route, maybe suddenly the short latency response will become a long latency response because the conduction velocity is impaired, and maybe the amplitude gets smaller. And then as a surgeon, if you stimulate this sick route, let's say, or this affected route, you cannot anymore say, is this sensory or is this motor? And then if you want to decide if you can cut it or not, it might be difficult. So we took again the concept of the double pulse technique, also described by Minassian already many years ago, to see the recovery time of the reflex to differentiate between motor and sensory. So we gave this double response with an inter-frame or inter-pulse interval of 60 milliseconds, And if we got only one response, we would know this is motor because this is sensory because the synapse is still blocked. But if we stimulate the motor route, we should get two responses because there is no synapse. We are behind or distal from the synapse, so we get the double response. So, and we use this technique to guide our lipoma surgery. So to stop here, I think we have talked about the integration of the surgical, neurophysiological, and oncological strategy. We talked a little bit about patient outcome and evidence. And just again, I want to mention, if you're interested to participate in the Spine Tango initiatives, you can scan the QR code and you come via the ISIN webpage to this registry and also instruction. And for sure, again, we should not forget, we are there for our patients. And for me, coming to India, it was always a highlight coming with the different centers to the operating room and to share our experience both sides. It was really always a highlight for me. And we have not to forget that we are there for our patients. And then finally, as it's only a virtual symposium, I hope I see many, many of you in Mumbai. There will be a whole week of intensive neurophysiologists, neurosurgeons, neuroanesthesiologists, technicians, and scientists together. So I'm really much looking forward. You see the QR code, you can scan it. And then for sure, there's a whole team behind it. And I thank you for giving me the opportunity to participate in this wonderful webinar. Thank you.
Thank you, madam. That was a wonderful talk on intramedullary tumors as usual. You rocked it. We'll go for the questions one by one. I think the panelist, Dr. Arivalagan and Dr. Anand is also with us. They'll also help us in understanding some few questions. The first question will go to Dr. Sushant Sahu. So the question is, what troubleshooting steps do you recommend if there is a sudden MEP loss occurs during insular recession? Dr. Sushant is there? I think Dr. Kathleen can answer this one. If there is a what troubleshooting things you will do if sudden MEP loss occurs during insular resection?
Yeah, this is a challenge because one thing is like you have to understand what at which step of the surgery you might lose your MEPs, right? So if it's during preparation of the Sylvian fissure or manipulation there, and you have this Trans-Sylvian approach, then like everything, preventing vasospasm will help you. So you can discuss if you elevate the blood pressure. Some groups like to give nimodipine or papaverine. So you can do something to improve the vasospasm and you may get your sickness back. However, the most dangerous or difficult part in insular gliomas is that you cause an ischemia of the lenticulostriatal artery, right? And these are these nasty perforators, and especially if you approach the tumor from fronto-opercular, they look like this in front of you. And if you coagulate them, you might get an ischemia. And this is an ischemia of the capsula interna. And unfortunately, there's no way to get the sickness back. This will just tell you that this is the last step. To help, you might use a little bit mapping before to get an idea towards the distance of the cortical spinal tract. And then you might understand where is the anatomy from this lenticulostriatal arteries towards your resection cavity. And so there maybe a mapping will help as well. But coming back to the questions, yes, if vasospasm is the topic, you have a lot of things you can do. If it's like pure ischemia, maybe it's just a warning to predict that this was not a good step.
Okay, the next question goes to Dr. Edmund. Dr. Edmund, there's a question saying that how to get a baseline MEP recording in a severe spastic cervical myelopathy patients in which the power is normal, but the patient has neuric grade 5 and a severe spasticity is there. Can we get a good baseline MEPs for these cases? Dr. Edmund.
Prabhu, usually in those patients who are neuric 5, it's very difficult to get a signal. So as a baseline function, we don't usually monitor for those patients with severe myelopathy. But if they are neuric 2 or neuric 3, we definitely try to get the signals.
And it's unusual to have 5/5 power with a neuric 5 grade myelopathy.
Exactly.
The other point is, if you are the same way, suppose you are monitoring the MEP, there was no MEP, but if you release the myelopathy, if you release the laminectomy, you do a decompressive laminectomy, this MEPs comes back sometimes. We have seen that the MEPs comes back. So is it advisable to put the MEP and just wait even if it is not coming?
As a usual practice that we have been doing, Dr. Prabhu, we have not been monitoring for patients with severe canal stenosis with DCM and also for CVJ. But if the patient is neuric 2 or neuric 3, and if there are minimal baseline signals, we tend to monitor it till the end of the surgery to see if there is an improvement. And we have seen in few cases there is definitely an improvement. But for neuric 5, we usually do not monitor any modalities as a standard practice.
Okay, thank you. The next question, I think Dr. Anand can answer this. What type of stimulation can we give to if the tumor is fully covered the motor area? That's what the question asked. If the tumor is fully covered in the motor area, whether you prefer bipolar or you prefer monopolar?
Well, for cortical mapping, we prefer monopolar. We should be able to get whether the tumor is fully covering, motor cortex is fully covering the tumor or not. Once you map, then you can decide on which area to enter to get into the tumor. So if for the bipolar, yes, it may work, but I think monopolar is preferable.
Okay, the another question goes to Dr. Kathleen. So you were telling about the corticospinal tract, we can just map it by means of monopolar. Can we say the distance between the tumor and the corticospinal tract in the spinal cord also by this same technique? Dr. Kathleen.
This is a very good question. So what we do for mapping, we use a bipolar concentric probe. So it's not monopolar, it's bipolar concentric. And the idea is because everything is so close. And that's why we don't have an idea of distance, because everything is so close. So maybe there is a distance correlation, but the current is already spreading everywhere. So we didn't establish any distance protocol. However, what we do for motor mapping, we start with 2 milliamps or 3 milliamps, and then we go down to 1 or 0.5, and if we get response, we stop there. Sometimes we can even go down to 0.2. But I would suggest to stop early because everything is so close within the cord.
So, Dr. Kathleen, or just for clarification. So, Dr. Kathleen, in brain you use monopolar for subcortical stimulation, whereas in spinal cord you prefer bipolar. Is that what you told correct just now?
Yes, so correct. For the supratentorial, we use a monopolar probe. For the intramedullary, we use a bipolar concentric probe. And I think it doesn't matter. You can use a monopolar probe. It's not about the probe, it's about the paradigm. But maybe if you have a bipolar concentric, you are a little bit more focal than a monopolar. If you only have a monopolar, stay with the monopolar, is fine. But you just need to decrease the stimulation intensity. So it's always train stimulation. In the subcortical supratentorial, it's a train of 5. And for the spinal cord, it's a train of 3. But it's, again, always train, so never pen field. And the probe, it's not so important. But the importance is that you have the train to get the triggered MEP response. But correct, we use a monopolar for supratentorial and bipolar concentric, bipolar coaxial for intramedullary. But it's not so important the probe, it's more the train.
Thank you.
So,
and for the D wave, Kathleen, just clarify for the D wave. What would you do for the D wave? It's the same train?
So for the D wave, we stimulate supratentorial, right? We use a single pulse stimulation. So it's a single pulse because it's a D wave. And then for the anti-D wave, you would do also, you stimulate you use the catheter of the anti-D wave and you record from the cortex, and it's a single pulse again, but you average. And if you stimulate to record the D wave, we don't average.
Thank you. Thank you.
The question is to Dr. Vishaka. So when you do BCR, do you prefer putting a urinary catheter with the stimulation probes? That will be preferable, or you just put a needle electrode or a patch electrode on the surface of the dorsal penis like that?
We just put a needle or patch electrode, sir. We don't have experience in using with the catheter.
Okay.
We use a catheter, and we try to hitch the catheter down a little forcibly so that the sphincter will contract around the bulb, and we may be able to, we can pressure transduce the bulb which you have inflated. We have tried that to see pressure changes in the bulb in a waveform. So this can indirectly show you about the urinary sphincter. I don't know whether it has been described, but we use it sometimes.
Now in market it is available with the leads itself, which has been put up on the catheter, and
Correct.
we can just monitor the
Yeah, if you don't have them, even with the regular Foleys, but transducing the pressure transducer on the bulb, you can get variation in that, but it may not be foolproof. If you get it, you're lucky.
The next question, I think Sushant is not there, but the same question.
Yes, I am here, sir.
Sushant came back. Sushant came back.
So
I am here actually.
yeah. Your question is there is any threshold for stimulation of subcortical speech mapping of tracts? Does it also correlate with the distance from the tract as with the corticospinal tract?
Exactly,
So
actually. Yeah, got it. So particularly for the language mapping, actually the physiology is not like what is happening with the corticospinal tracts, because corticospinal tracts are the clear-cut myelinated tracts. But in case of these language fibers, these are interconnected. Multiple synapses are there also. So they don't correlate exactly with what milliampere you are doing, and you are getting the response. So in the current threshold, what we do is we stimulate gradually from the low down from 2 milliamps, gradually go up, and at a particular current when you are getting the language, we just stop there. If you go beyond that, it will stimulate further tracts, and it will depolarize the cells. If you are doing on the cortex, it will induce seizure, and then the subcortical, I don't think that it will correspond directly with the milliamps equal to those millimeter what is happening with the corticospinal. It is not directly correlating with the language, sir.
The another question is the same to Dr. Sushant. Do you have any experience in bilingual mapping of speech areas?
Bilingual, sir, exactly. No, we do not have, personally, I do not have experience of this bilingual, although we have some patients like Punjabi speaking with Hindi, Punjabi with English. But this dissociation, personally, I don't have any experience of this bilingual dissociation. So exactly, what is the question? The question is bilingual dissociation during surgery or bilingual mapping during surgery, that is.
Bilingual mapping. And
Bilingual.
what is the importance of bilingual mapping?
No. Personally, I have not yet started this practice of using this bilingual mapping.
Dr. Kathleen?
Yeah.
Maybe Dr. Kathleen.
I wanted to ask this question even because I think it's super interesting. So I think on the cortex you can see this because we also have a lot of bilingual, so German and French, or French and Italian speaking patients in Switzerland. So bilinguality is a problem or an opportunity. And also then these patients move, right? So they are grown up in the French part, but now they live in the German part, so they speak mostly German. So it's not anymore their mother tongue, so it's even getting more complex. So on the cortex, sometimes you see difference in the error rate. But I was wondering, do you see a difference, a dissociation in the subcortical mapping? And
I
until
think
now, we have not seen this, but I don't know. I
I
don't
think
have an answer.
I think Dr. Dufo has published a lot in that
Yes.
in the different, not just bilingual, multilingual mapping. And I
Yes,
think in our
he,
place also we have done. Prabhu has done few cases. I have got few cases where intra-op and post-op patients have selectively developed deficit in one language.
Yes, I have seen
Uh,
this as well. And as I
yeah,
say, you also
yeah,
see this on mapping of the cortex. But
yes.
I'm not aware, even for Dufault, if you stimulate the subcortical white matter, so let's say the ARCWOT or the IFOR, or different tracks, do you see like different responses for different languages, let's say, in the pathway? So on the cortex, yes, because you recruit different areas, maybe memory areas and so on. And in the outcome, you see a difference. But do you see a difference in subcortical stimulation? This is, I'm wondering.
Yeah.
A lot of work has to be done because still I'm able to find out only in the cortex area there are two representations are there, but in subcortical still uh, we are not able to find out the bilingual representation in the subcortical tracts.
Yeah, it is possible that there is a lot of network activity, and then it may be very difficult to pick it up transiently, but definitely we can have post-op. And what I have noticed in at least three patients is when a patient has multilingualism, the native language, that is a mother tongue, is more resistant, and they get preserved, whereas the second or third language that is taught often gets affected, and which improves over a period of time. Of course, but then these are like if you have to if you have to identify functional subcortical fibers for different language, I don't think we have that kind of data now. Is that correct?
I think, sir, these data need to be correlated with the cortical structure. Then only
Yeah.
we'll be able to like educate more and more about this.
This question is to Dr. Kathleen. We have already discussed the same thing in SionCon last year. The previous idea is if MEPs are dropping down in a case of intramedullary tumor, but if the D waves are present and it is above 50% preserved, then you continue the surgery. But the recent paper, it shows that even if the D waves are preserved, but the MEPs are dropping down, and if it is not picked up, even after recoverable things are done, then you have to expect a permanent deficit in a long-term run. That's what some papers are coming out. What is your experience in this?
Yeah, so the experience, I think we have to dissect a little bit where is the problem. So if you like, the D wave monitors the cortical spinal tract pathways. So if you lose the MEPs for the leg, but the D wave is preserved, the patient will have motor functions of the leg roughly fine in the long term. However, what you can create, let's say you have a tumor in the cervical cord, D wave is fine, MEPs of the legs are going down, the MEPs, the motor function long term for the leg will be fine. However, what you can do on the level of the lesion, so let's say this tumor, the child I showed, so on C6, C7, you might injure the motor root of this patient or the alpha motor neurons or the motor horn, let's say intramedullary. And then you have a weakness in the intrinsic hand muscles of the left hand. For example, in this patient I showed, she had a weakness in this hand, but the motor function on the right hand was fine and the legs were fine. So the DWAF was preserved, but here she had a loss of the APB. So you can have isolated losses of some muscles, but on the segmental level. But what I think you cannot have, that you lose your MEPs from the tract, let's say from all the legs or from one part of the leg, but the D wave is preserved and the patient has a permanent deficit. This I don't think so. But what these recent papers show a little bit on the segmental level, you can have an injury. And this is not picked by the D wave because the D wave doesn't see gray matter. It only sees the white matter.
Okay, so something, the recent past, a lot of papers are coming out, and a lot of talks I am hearing about H reflex. Is the H reflex has any value in intramedullary tumor? What is the recent publication says, or what is the level of evidence in which H reflex is helping out like in D wave or MEP? Is it equal to that, or is still in the emerging phase?
So the question is for me, right?
Yes.
Yeah.
Yes, yes. So I think this is a good technique. There's still not enough clinical validation, but the age reflex, what it would see is the problem what we just discussed. It would see the segmental level, right? So it's not replacing the D wave because the D wave sees the long tract. And it's not replacing MEP and SCP because most of them see the long tract. But if you are like, let's say, on one level in the conomedullaris, let's say, you would have the age reflex would be super beautiful because it would see the conus medullaris, right? Because it would show you the segments. The problem is a little bit of vulnerability to the anesthesia. But once this problem is fixed, I think it's a great adjunct to see something more. But it's not replacing anything. But it sees the gray and the white matter of the segment and one segment up, above, and below. So you can see this like this chip of the spinal cord. I think it's a beautiful technique.
Yeah. Can I ask a question to Dr. Kathleen?
Yeah. Yes, please.
Dr. Kathleen, recently I was asked this question by one of the attendees in a meeting, and I did not have an answer. I'll repeat the question to you because this is something which is quite relevant for all of us. Whenever we operate cervical intramedullary tumor, high cervical cord tumor, we are always worried whether the patient will come out of anesthesia and will not get into a ventilator for long. So the question was here, we had talked, like you showed, we can do MEP, SSCP, and D wave. Is there any way, or is there anything that is coming up to assess the diaphragmatic movement or respiratory functions when you're operating at a high cervical intramedullary tumor? Can any mapping monitoring help us to say that we are not injuring the respiration control of these patients?
That's a very good question. And yes, we try to do this. So we monitor the diaphragm. So for the neurophysiologist, you can place your EMG needles right to the intercostal line and so on. So we place needles, but we don't place them exactly in the diaphragm, but just close. So for the mapping, we would get a response, even if it's a little bit of far-field response. For the MEPs, it's difficult because then you really need to be in the muscle. So if you have the knowledge to really place it in the muscle, maybe you're better off. Sometimes I'm afraid because in this preoperative setting, if you would injure like the pleura and then you get a collapse of the lung, you mess up with the whole surgery. So we place needles, intercostal line, and so on, but not exactly in the diaphragm, but close. And then at least for the mapping, we can get the response from the diaphragm, so we know we are close. I think it's maybe helpful, yes. So we did this. And I think some other centers are doing this, but not many. So it's a very good question.
Thank you.
This question is to Dr. Arivalagan and Dr. Anand. There is a question in the chat box saying that they are all young physiologists and some IONM electrophysiologists. So they want to experience this intraoperative neuromonitoring as a maybe a observership or something. So they are asking how to go about for this observership or a short-term training. From the SION, what steps has been taken up to help these persons?
Dr. Anand, you would like to go ahead?
Yeah, I think in SEON we had discussed this in detail with our ex-president, Dr. Ashok Jarial too, where we were planning to have centers which are accredited based upon the number of cases that are being done and try to match them with prospective trainees or who want to gain expertise in a particular area. So I think Dr. Srinivas Babu and Dr. Ashok, we are trying to work out this accreditation kind of number of centers which can give that. So I think it's not an easy process. It's difficult because the number of centers are, though they are there, the numbers, what is the period of time, how many cases that they are likely to see, whether it is cranial, whether it is spinal. So there are so many other subdivisions that creep in. So we don't know whether 3 months is adequate, few weeks are adequate, or it has to be 6 months or 1 year. Do we give a fellowship? Or the best way as of now to do is for the candidate themselves to figure out from meetings which are the areas or centers which are doing the kind of work they want to get exposed to, and directly contact them and go for observership with them. But otherwise, as a society, I think it's going to take a little while, but we are trying to get there.
I'll just like to add with what Dr. Anand said. I think it is we have to look at it in two ways. If I think if we have to get a certified training, which I think should be the way forward, instead of just making it informal experience of 1 month, 2 month, 3 month, and diluting the whole field. Dr. Prabhu asked, he clubbed two groups. One is MD physiology or the physiologists and the technicians. I think we'll first take the technicians. The technicians, most of them undergo either a diploma or a bachelor's course in clinical neurophysiology training, which is usually or in most places is extra operative training, which is like a neurology centric training in labs, which will give a baseline knowledge of doing most of these techniques, whereas does not give a practical experience of working in the operating theaters. And that said, now slowly we have to understand that this is a nascent field as far as training is concerned. And so now we know that there is a training program which is there in Tata Memorial for 1 year. Nimans gives a training for I think 4 months, and then there are other centers which are coming up. I'm sure over a period of time these numbers will increase, so that those who have basic bachelor's or diploma training in neurophysiology technologists can take this extra additional 3 months or 6 month courses, which will give them certified experience for doing this. As far as the physiologist is concerned, I think I'm not sure if many centers give additional fellowship of subject. Most of the physiologists who are in the field have learned it kind of on the go, because once you get into that with your again basic degree training, it over a period of 3 to 6 months, they get experienced both with workshops as well as training. Because I don't think from neurophysiology side there are many centers which gives an add-on like a PDF in this field. I think that is something which the physiology society is looking at. If centers can start, this is coming up. I think AIMS Bhubaneswar, there are 2-3 centers where structured training courses are coming up for different groups, physiologists, technologies, and all that. And as far as neurosurgeons, also most of us learn by doing the techniques. We don't have a separate kind of fellowships in for neurosurgeons to get into this, because this again is a technology which comes through experience. And from the society, yes, the only thing we can do is to see streamlined these procedures when possible. And second is to disseminate the knowledge to the larger group, so that they are aware what is available and where it is available. That's what we are looking at.
I think the further things will be put up in the SION website. Maybe the training and other things will be put up,
Yes.
so that the students can look into the website and know a lot of things. Along with us, Dr. Matthew is there. Sir, you want to tell he is the webinar convener from the NSI. Dr. Matthew, sir. Okay, Dr. Arivalagan and Dr. Anand, any questions you want to ask so that we'll wind up this section?
No, I think we are good. We had a very lively discussion and lot of questions starting from basics to advanced. You can conclude from my side.
This was a very wonderful. Yes, sir.
Sorry, the only point with you, Prabhuraj and Kathleen being there, the only point that was left out is probably the cortico-cortical evoked potentials, which has not been touched in this seminar. Just for completion's sake, I'm just mentioning it. I know you people are doing pioneering work on that front, and it's very exciting to see how that is going to pan out, because we can do then almost all cases asleep than doing awake. So
I'm not sure, sir. I agree
for people to look up.
I am not sure. I agree to disagree on that.
I think it's a good technique to start. But I also agree at the moment it will not replace the surgery at all. It's an adjunct, like, and I think it's like all the technologies we have, they have to complement each other. So it's a monitoring technique in a wake craniotomy where you have mapping, but it has to be validated in the future. And there will be an ISIN webinar soon in summer with also Ricky Matsumoto and some other speakers to discuss about the CSEPs. So also like you can also check ISIN website and maybe there will be a whole hour about CSEPs. And yes, I totally agree. It's a promising technique, but we have to learn a lot still.
Yes,
right?
it has a lot of potentials to give further knowledge in so many networks. I'm sure we'll be finding more networks in this field with the cortical evoke potentials.
Thank you.
Thank you very much.
As we started in the beginning, I told that this is only 2 hours webinar, which cannot be covered many things. We didn't touch the brainstem, we didn't touch the posterior fossa, we didn't touch dorsal rhizotomy, vascular. So I have asked the NSI if there is a second part of IONM is there, then we can maybe after 6 months later on we can have a webinar on other things so that we can at least cover. So we have struggled for 3 days to cover the whole thing in the SeonCon. That cannot be done in 2 hours, I think. So I really thank my co-moderators, Dr. Kodishwaran and Dr. Matthew, who has given us an opportunity to conduct this webinar. I especially thank the speaker, the international speaker, Dr. Kathleen, the national speaker, Dr. Rupesh, Dr. Edmund, Dr. Shushant, and Dr. Vishaka, the panelists, Dr. Arivaragan and Dr. Anand, and all the participants. And we can see that the participant went up to 160 in number, and now it is around 100. So the 160 itself for a NSI webinar is very high. I think we can continue these type of webinars regularly so that it will benefit many people ahead. So thank you. And anything else if you want to tell, we can tell and then close the section.
Thanks a lot for this, arranging this, Dr. Prabhuraj. And thanks, Dr. Kathleen, for being here with us again. And thank all the speakers. Thank you.
Thank you so much.
Thank you everyone for the wonderful questions and discussions. I learned a lot.
Thank you. Thank you. By this, we end this section. Thank you.
Thank you.
Thank you. Have a good day.
Bye-bye.